The next defect is the pulmonary atresia with impact ventricular septum, which represents around less than 1% of all congenital heart diseases. And this disease, 80% of cases have pulmonary valve as a diaphragm-like membrane separating the right ventricular outflow tract and the main pulmonary trunk. In 80%, the infundibulum is also atretic. Rarely, the valve ring and the main pulmonary artery are entirely hypoplastic. Usually, the pulmonary artery are confluent, which means both pulmonary artery branches are in direct continuation with the main pulmonary artery. And in such case, the pulmonary blood flow is only provided through a PTA or collaterals. And for survival, a patient needs an adequate interatrial communication and a PTA. These patients present with history of cyanosis since birth. By examination, the patient is cyanotic, tachypnic, with single second sound. There is a soft murmur of tricuspid reverse, or a continuous murmur of PDA may be audible. If the interatrial communication is inadequate, we can elicit hepatomegaly. ECG shows a normal QRS axis, left ventricular hypertrophy, and possibly right atrial hypertrophy. The heart size is usually normal. However, there may be right atrial enlargement. Pulmonary vasculature is usually diminished. Echocardiography is characteristic for disease pathology. Cardiac catheterization may be required for patients of pulmonary atresia to show the right ventricular cavity. Without intervention, the prognosis is very poor. Almost 50% of these patients die by the end of the first month, and 80% will die by the age of 6 months. Management includes medical, cath intervention, and surgical intervention. Once these patients are diagnosed, prostaglandin E1 infusion should be started to maintain PDA patency. Some centers perform PDA stenting, and in other centers, where the pulmonary valve is a membrane, radiofrequency perforation of the pulmonary valve, followed by balloon pulmonary valvuloplasty, can be used to establish right ventricular outflow tract to pulmonary artery continuity. Surgical intervention depends on the size of the RV. If the RV size is adequate, biventricular repair is usually feasible. If it's not, so the patient goes into the univentricular repair option, ending by Fontaine operation.